All right, we're here for another episode of Unstable Vitals. I'm Dr. Adam Brown, and I'm with my good friend, Dr. Lara Zibners.
That's me.
Yes, and we are here today to talk about patients, profits, and misaligned incentives in the healthcare in the system
That
in the
has
U.S.
nothing to do with healthcare in the United States, Adam. I don't know
No,
what you're talking
they're
about.
all exactly.
Everything is completely aligned for the benefit of patients, physicians, and the system.
And the system.
I mean, the last I checked, it works perfectly. I think our job is done.
Well, so let me speak of that. So my husband, as you know, is a UK citizen. And so he says when things are not great, he'll say things are perfectly adequate, which I think is a way of kind of describing like this pretty much sucks. And I know this because of like when I've cooked for him before, and I kind of know it's a shitty meal. And then I'll cook it and I'm like, Steve, how does this taste? He goes, it's perfectly adequate. And so I know that means
perfectly adequate.
Meaning it does provide some sustenance.
Right. You're not actively trying to murder him with that meal. It's not like that case down in Australia where she slipped those mushrooms into the beef Wellington and half the family died within 3 days.
What kind of mushrooms were these?
Not the ones you're supposed to eat.
And not the fun ones.
And not the fun ones. They're the ones you're not supposed to eat, and you're certainly not supposed to put them in a beef Wellington you're serving to your family.
Oh, wow.
Yeah.
Wow.
Someone was having a bad day.
Or someone's
Menopause
been researching.
Is a bitch.
Someone's been
Just
researching
saying.
this way too much.
That's right.
Rob, watch out. Anyway, so no, what we're going to talk about though is the incentive structure in the U.S. healthcare system and how it has created, in some ways, a lot of instability, and how it's made the system unstable. I mean, I don't know. I kind of think it's unstable. What do you think?
It's perfectly adequate.
It's perfectly bingo. Good answer. Well, we talked about this a lot in my class at UNC. And
right, where I found out how little I actually understood about healthcare.
Well, I have to say.
Despite being a highly educated woman.
With how many master's degrees and a doctorate?
Two and one doctorate.
Yeah, that's right.
That's right.
Yeah, that's a perfectly adequate type of education that you have there, Laura. But I think when you start to look at what are some of the problems, they really do ladder up to a financial incentive misalignment. And it's a healthcare system that has a certain number of problems that all go back to that, meaning whether it's drug pricing or physician pricing or how doctors interact with the market, how medical school teaching occurs, all the way down to how patients are accessing healthcare. It goes back to those incentive issues.
And I was going to say it's unique in the U.S. because healthcare is not a right. This is one of the few places in the world where healthcare is just not a right. But even in countries where healthcare is a right, there still are for-profit models within those systems. So it's not unique to the United States, but the United States is particularly problematic because somehow we don't think basic human health care is something that everyone should have.
That's right. One of the questions that I oftentimes like to ask is first, what is health? What does that mean? That's kind of a fundamental question as we start talking about how to fix the system, because we talk about health care, and presumably that means something of we are doing something for someone to improve their health. But then what does the word health actually mean?
Well, we talk about poor health as well. So we muddy the waters because to me, health would mean I don't need a doctor.
And that's funny because I ask a lot of students sometimes and they immediately go to the word, well, health means life without disease. But then I ask the question, we know several people, we can list them, we can name them, maybe ourselves, that have health conditions or disease conditions, but yet we still feel and are healthy. So it's more than just that.
Right. And when we go with strict definitions of healthy, not healthy, we leave out things like mental health.
Well, right. So people have depression, anxiety, they live with those disease processes, and yet they can still be healthy, they can still be active, they can still live happy lives, they can still lead productive lives. And so why am I bringing this up? Because if we're talking about incentives, we have to discuss like, what are we incentivizing? Are we incentivizing the health of humans? Are we incentivizing the financial health of a corporation? Where really does that incentive lie? Because there are misaligned incentives, but then you have to get back to the definition, the basics of what is health. So we've gone, when I've talked to my students, talked with other colleagues, we've discussed things that health means wellness. Well, then what does wellness mean? And what does longevity mean? Does it mean a number? Is it a quantity? Is it a quality?
Yeah, but now we're starting to get into soft qualitative markers. And the minute you get into qualitative markers, you open the door for the snakes oil salesman.
That's
So
exactly right.
wellness now actually kind of has a dirty connotation, and so does longevity, right? Like,
Well, I mean, let's talk about the incentive kind of maze. So we've talked about, health is hard to qualify and quantify. If we look at, the world of which countries are healthier, there's certain things that we look at. We look at how old people actually live before they die. We talk about the rates of cancer, rates of suicide, depression. We talk about maternal, fetal health. And if we kind of break down the United States healthcare system, we are very unhealthy by those metrics.
yeah.
We spend more than any other developed nation for healthcare, and yet we have 3 to 4 years less life expectancy than Switzerland, Japan, the UK, other countries.
Well, and women live longer than men, but they live a good number of years in a state of frailty, of poor health, of needing. They're not independent. They're not. You could argue that they're not able to do the things that would make that long life more meaningful at the other end.
And so that is a hybrid between the qualitative and quantitative piece of it. So, it could be a quantitative where women have a loss of bone density, which makes that, and that also plays into the ability for them to move and have mobility and flexibility, which also has life quality sort of issues associated with it. So the United States has spent so much money on disease management. We do really great with cancer care. We do really poor with preventive care for hospitalizations.
But you can't put a finger on the dollars made by keeping somebody healthy. You can certainly put your finger on the amount of money that surgery to replace your knee costs.
Exactly. So fundamentally, in the U.S. healthcare system, we have decided to have what we would call a fee-for-service system. And that is just simply, think about when you go to a restaurant and you buy something on a menu. The more you buy, the more you pay. And the incentive on the part of the restaurant is to sell you more. It's
That's
to
right.
position things in such a way to buy the special of the month.
Add the truffle supplement.
Yeah. I don't like truffles.
So that's a problem. That's a you problem.
It is
'cause
a me
truffles
problem,
are fabulous.
I don't like them. They
And
truffleicize
umami.
everything.
That's a you. I'm just gonna say let's just keep that to yourself. That's a you problem.
I don't like
okay?
them. I mean, when people are
Fine.
like, "Would you
Have the
like
caviar supplement.
No, when people are like, "Do you want French fries?" I just want basic damn French fries. I don't want this truffle shit on top of it, or truffle oil. Just make it basic. And you can't eat French fries. Side note, very much because they're bad for you. But still, I don't want.
You can eat truffle on eggs, and that's perfectly healthy.
I don't want that. No.
And I like caviar on
Okay,
my
sure.
oysters because that's pure protein, and we all need more protein, especially those of us who are menopausal.
Okay, I don't disagree with that. But we're fee for service.
Right.
And so the more we do, the more we get paid as a healthcare system. The more a pharma company makes by the more drugs that they sell, the more a hospital makes by the more people that are in the beds, the more a doctor makes. That's very different than what we call a capitated system, or a system like in the United Kingdom or in Germany or in France, where there's more of a here's the budget, you have to operate in it country. Here's the people you have to take care of, and you have to think of innovative ways to try to take care of those patients and still maintain certain levels of quality.
Well, and I think what the U.S., most people in the U.S. really don't understand, I did not understand until I moved to the UK in 2006, was that these systems, that's not all of healthcare.
Right.
You can still go there and pay out of pocket for a different level. And depending on the country, it's graduated. Maybe, there's a medium tier, or a lot in London, you see a lot of private medicine, which is very fee for service. But that's a choice. What we're talking about is a basic safety net. Right?
Correct.
For people. We're not talking, again, if there was endless piles of money, every country would have perfect preventative healthcare systems and no one would ever get sick and it would be great.
Right. But the the system in the US, the safety net has often been described as the emergency department is the
Oh,
safety net.
yeah.
However, that's not accurate because there's costs associated with it to the patient. They're still billed. We just are responsible as emergency physicians for taking care of those patients, irrespective of their ability to pay. But then they still get billed after
That's
they
right.
walk out the
That's
door.
right.
So there's a disincentive for them coming in to seek healthcare. So you have the fee-for-service system. You have these capitated systems, these systems that have a fixed amount of money going into the system, and whatever is extracted out of the system is money that goes to the people who are providing care. But and the money that's left over is money that's left over. But there's issues with some of that as well. Then there's the
Yes.
blend. You
Yes.
know, we talked about here in the UK, you have the blend between some private insurance. Again, if you can afford it,
Right.
you know, you can go to private
Well, and some of that
clinics.
is part of your employment package,
Correct.
right? So it's not just that it's NHS or, totally out of pocket. You can get insurance, such as the Bupa model,
Right.
right? But they, it's a business at the end of the day. So I had Bupa for 6.5 seconds and realized it wasn't going to cover any of my pre-existing conditions. So I went to a different plan that is more of a global plan.
Well, I mean, so in the U.S., you talked about the private insurance system. There is no base insurance for everyone in the U.S. I mean, this again is you would have to pay out of pocket for any services that you get from a doctor or hospital emergency department. That doesn't mean you necessarily always have to pay up front. Again, if it's in a medical emergency, you get seen in the emergency department, then you have to pay on the back end. But our insurance system has also been set up in the United States in such a way that we mostly get our insurance through our employers, unless you're over the age of 65 or you're a lower income individual through Medicaid, or an older individual through Medicare. But there's still no baseline. And here, even though you were like, Bupa doesn't really cover me because Bupa is the private insurance here in the UK. But if you had those pre-existing conditions, like, okay, I'm going to choose another plan. But even if you didn't choose another plan, you would still be on the national health system and you would still be able to seek care and you would not get a bill, correct?
That is correct. Now, there are some nuances there. You're not supposed to be eligible for NHS services if you are not a UK resident. So you're supposed to be able to provide an address, but nobody really ever chases that, right? If you show up and you're on holiday from the US and you sprained your ankle and you go in, they might, technically, I think you're supposed to pay for it. I'm not sure they know how to do that, though, because it's so rare that I've never had that issue. But we lived here for a long time. And I'll say, I worked in an NHS-funded hospital. Trauma and emergency medicine is one of the few areas that you cannot private your way out of, right? You are in the system if you're in the system. And that's a system you want to be in because they're built to take on bad accidents. My daughter broke her arm, and we got fabulous care. Partly because it was my hospital, so I made some calls ahead of time, but partly because that's just what we did. They did find a pillow for me so that I could sleep on the cot next to her bed, and but we had a great experience. For things that were more minor, you wouldn't get that same because there's only so much money to go around, right?
Right. So when you kind of look at the systems, again, fee for service, capitated models, we have an insurance system in the US. And so you get this really mix or stew of incentives. So insurance companies, they get money from premiums, or they get money from an employer and through premiums and through co-payments to or co-insurance payments to kind of have money up front. So then they don't necessarily want you to go to the hospital.
Well, because let's back up. I don't think a lot of people understand how insurance works. You collect premiums, not so that you're like a charity sitting there with a big bucket of money waiting for your patients to come to you needing something. You take that money and you invest it. And your bet, and this is pretty much insurance's like whole model for any kind of insurance, as far as I understand, because I'm not an insurance expert. I'm just me. But anyway, you get premiums, and your hope is that nobody needs it, while you can make more money by investing it elsewhere, using it, putting that money to work for you, right? You make money off other people's money, and then you hope that at the end of the day, you've made more than you've had to spend.
Well, yes. Now the big insurance companies in the U.S. for healthcare, like United Healthcare, Cigna, Aetna, They do things a little bit differently because they're very vertically integrated. So when you talked about these companies investing, many times they're using the money that they get from premium support to pay for or buy other integrated services so that it reduces their profitability in the insurance section. We'll get
No, it
into that.
increases their profit.
No.
No.
You want to decrease the profitability in the insurance segment of the business so the profits roll up to the parent company through the
Right.
other
So
verticals.
overall, you are spending less money by taking other people's money to do things for yourself that will help you make money.
Okay. Hold that thought, sort of. We'll get there because the insurance side is very complex because of some of the laws that have been written to try to prevent profitability on the backs of patients. So we'll talk about that. But going back to the incentives, the incentive piece, so you have the everyone's wanting to do more, so they get paid more. And if you look at, well, where do the patients sit in this? The patients just want really great health care. They just want to be taken care of, and they want to know that the best care that they're getting is the care that's available and that they're not getting short shrift if they don't have money. They want to have good health care. And they assume that if they have a national type of insurance logo on their card, whether it's United, Cigna, Aetna, one of the big companies, they're going to get good care. Well, the doctors want to take really good care of patients. They want to see patients. I've never met a doctor, maybe one, but like I've never met a doctor that has been like, I want to screw over patients. Like that's not a thing. But they also want to ensure that they're able to keep the lights on in their clinic, or that they're not being treated unfairly, or that they're not having to run through all these administrative hurdles in order to boost the profitability of an insurance company, which the insurance company should, when we use the word should, be helping with the care of the patient. But we know that should is not being traded on the stockroom floor.
One of the best things that my parents ever made me do is, my dad's a radiologist out in California, or is retired now. And when I was about to go to medical school, I had 9 months off between the end of uni and med school. And I went and worked in the billing office of my dad's practice. And my job was to take all the statements that were rejections from the original
So they're
submission.
called denials.
Yes, the denials. And then decide whether it was something to write off. So if it was under like $5, okay, not worth my time. Or if it was something that I was going to send and it would depend on which the insurance was and what the procedure was. And very quickly, this 21-year-old kid learned real fast that you could not tell on paper which plan a patient was in, because it mattered if they were in the HMO plan or the PPO plan or the whatever plan, and the plan, XYZ. So I got so annoyed that I threw a big hissy fit, and because my dad was president of the group, they actually sent a rep out from one of the insurance companies, and I said, how do I know, looking at this piece of paper, which of your plans the patient's enrolled in? And he said, you do not. I said, thank you for clarifying.
Yeah.
Now, please put the donut down and go.
But that's the problem, right? So the incentive on the part of the payer or the insurance company is they want to take the money in from the patients or from the employers or from the government. If they are a Medicare Advantage plan, they are taking money from taxpayers, and then they want to hold on to it. Because the more they hold on to, the more profitability that they make, or the more they can invest into other service lines or other services, like other vertically integrated things. But then there's other things that are incentives, like that are misaligned. So one is even our medical education. I mean, in the US, we walk out of medical school on average $250,000 to $300,000 of debt. I mean, that is a house sitting in someone's head. When by the
Good
time
thing we can
you
live
pay it
inside our
off,
ginormous egos.
Egos, exactly. Whereas in other countries, it's not. And so that is a disincentive for doctors going into lower paid type of practices, like primary care.
Why would you want to be a pediatrician who comes out making $75,000, $90,000 a year? I'm a pediatrician, right? And I went to emergency medicine because that paid better, but it still didn't pay as much as the adult emergency medicine
with less
people.
training.
Even though, I trained twice as long.
Yep.
But if kids don't have the attention of their local lawmakers. Why should what's best for them be prioritized?
Right.
And so why would you go into primary care where you come out making under $100,000 a year when you're saddled with debt, and you're at a point also, let's point out, you're in your mid-30s, right? All your friends have already gotten married and divorced and remarried, and they've had a house, another house, they've got a couple dogs, the kids, whatever, and you're just starting your life.
Well, right. And I mean, even, this incentive issue, we talk about in the US, we want to focus on more preventive care and preventing chronic disease. And the specialties to do that are internal medicine and family practice. And there's others, of course, but those are kind of the basic ones in pediatrics. And yet those are some of the lowest funded and lowest reimbursed type of practices. So when you talk about incentives, a lot of the rationale for doctors making that early decision in their mid-20s of what specialty to go into is informed by, holy shit, I just walked out of university and I'm going to walk out of medical school hundreds of thousands of dollars in debt. I'm going to go to residency and fellowship for 3, 6 years, 7 years, making almost a minimum wage salary. And then, especially considering that you can work 80 hours in a singular week.
And that's with the new guidelines, because when I was a little doctor.
Yeah, I straddled that fence.
Yeah, we were contracted, I think, to 80 to 100, and depended on what rotation you were on. So I had months where I just came home and just crossed a big red X through that day, because those were the 120, 130-hour weeks.
Yeah.
And I was paid a whopping...
I think I calculated at one point I was paid $6 or $5 and something per hour while I was working as a doctor, as a resident in emergency medicine on our trauma service.
Yep. So I just snuck chicken breasts under my salad.
I thought you were going to say under your boob.
No, I don't need to put extra chicken breasts there. I'm fine, thanks, Adam. That's a kind of you problem. No, I used to, and I'm going to confess this now, to the hospital I trained at when I did my trauma rotation in 2003. I stole chicken breasts because I was so angry at the fact that we didn't even have a shower in our call room, and I would be there for 2 or 3 days in a row. So I took a chicken breast and I slid it under the lettuce so that I got my free $2 chicken breast, just to make myself feel a little bit better.
But think about that incentive. I mean, not the
not
chicken
proud
breast
of it.
No. But think about the incentive there. So you have a hospital. Hospitals are working on a certain margin, a small margin right now. They get paid by Medicare, by CMS, to have medical students and residents be a part of the program. They actually make money on top of that.
That's right.
And so they get paid around $115,000 per resident that they have coming in. It slides up and down. And then residents on average are making 60. So they're making a margin on that. Plus, they are able to bill at certain times for physician interface and physician interactions and get to reduce their costs, because the more residents that they have in their programs, the less attendings consultant physicians that they have in their programs. And therefore, they're able to then have a lower operation cost, lower contracting costs, and doing it on the back of residents. Now, residents have to learn, but think about the incentive there. The incentive is have more residents, build more residency programs. And one last thing, the more residents, the more residency programs, the bigger the pipeline, the lower the recruitment costs, and the suppression of pricing for physicians, which is something we've seen with other companies.
When I go back to that 2003 trauma rotation, that's the month that I memorized my DEA number, because this was during the opiate time where we were told, and we had no reason to question, you must give opiates to every single patient. They will never be addicted if you're treating pain. Correct. And if you did not send a patient home with a narcotic prescription, you got dinged. And these are like your training, because this is your career. So the people dinging you have control over where you get a job later. And so I wrote thousands and thousands of opiate prescriptions that month. And I memorized my DEA number because I was told I had to, and I didn't question it, because the hospital was being looked at. We have various metrics that they have to meet. And at that point, patient satisfaction, but more than that, that was when pain was a big thing. And hospitals were putting within their their metrics, how many patients are being treated adequately for pain.
Correct.
And we created a generation of
Opioid addicts.
yes.
Yeah. And so, I mean, but this again goes back to the misaligned incentives. If a hospital is paid off of patient satisfaction and someone decides that patient satisfaction is based on having no pain, and then patients are saying, hey, I don't have pain when I have large doses of narcotics, the incentive there is to prescribe narcotics. And that's what you and I, that was the prescribing land that we lived in the early 2000s.
That's right.
In the US and in residency. I remember so vividly the grand rounds conversations of pain is the fifth or sixth vital sign, and that there should be no one in pain. Recognizing, you and I recognize that like pain is a necessity to protect us at times, and to say like, ouch, I'm hurting in the right lower quadrant.
Exactly.
I have appendicitis.
I could get, I have a tendency to throw my back out. And I had one doctor going, I could inject that, but I'm worried knowing you, because we were neighbors. He's like, I see you at the gym all the time. And if I inject that, you're going to be over there doing some stupid stuff at the gym. I'd rather pain me. Yeah, me. So that's a me problem. Sometimes I do stupid stuff. You're going to end up making the damage worse because pain is protective. People who have neurologic conditions where they cannot feel pain, like, neuropathies, they're at risk for bad chronic injuries and foot sores and
diabetics.
Yes, pain is protective. But we were told, at least I was told, this is what is expected of you. And if you do not do this, you will be dinged.
Or you'll be on the bad boy, bad girl list.
That's right. And I don't like to be on that list.
I don't either.
I'm
Doctors
a people pleaser.
like to be people pleasers. Doctors like to stay in that kind of bell curve. They do not like to be cavaliers and kind of out there on either end. It is mortifying to be told that you are the worst at something. Which is
Have you ever been told that?
No. Well, yeah, on some things.
You going to tell us what those are?
Yeah. I'll get back to you on that.
I'm
not good at dating women.
I'm really bad at getting pregnant.
I can't comment at all on that.
But I'm not saying that was something you and I ever tried to do. I'm just saying.
No.
And it wouldn't work anyway now because I'm a bagless upright, right? The insides are out.
Okay.
But yeah, but now 7 rounds of IVF, not a single pregnancy test. Like go big or go home. If you're going to fail, do it like that.
Yeah. See, I'm not going to comment on that.
Okay, well, that's fine.
But I do like your bagless upright sort of thing.
I think that's a good term,
that's
right?
a pretty funny term. Like it's one of those things where you, in some ways, you think about it and you're like, oh, fuck, that's funny. Just like you kind of, I mean, I could not ever say that about you. You can say it and then I can laugh because you've given me that permission, but that is pretty damn funny.
I think it's pretty funny.
Yeah, I think it's very funny.
I mean, a hysterectomy is not for everyone, but it is for some people.
It's not for me.
No, it's probably not for you. I suggest
so for 50% of the population,
even
it's
fee
not.
for service doctors would be committing a crime, I think, if they booked you in for a hysterectomy.
Probably so.
Right? And
I would say so.
And forget a capitated care plan.
No.
No, that would not.
No, definitely not.
Okay, back to what we're talking about.
So back to what we're talking about. So think about it. So you've got all these incentives. Again, U.S. healthcare system, financially motivated to do more, to make more, because we're on a volume-based system.
That's right.
And so that fundamentally has several issues. It doesn't have a system that wants to make people healthy. And it doesn't mean that people are sitting in the background saying like, oh my God, how can I make Laura do one more round of IVF? Like there's not someone saying that. Like,
there wasn't anybody saying that. It was my doctor saying, and
let's fix this problem.
Let's fix this problem. I just feel like at some point it's going to work. And
right.
And I'm not the kind to say, oh no, I'm going to give up. Right. I'm going to be I'm going to be the last one dragged out of the nightclub kicking and screaming. Right.
Right.
Like I want one more dance.
But I think the real question of how we make things more stable, to kind of go back to kind of our goals, is it's easy to point at pharma and saying, "Ooh, big pharma, bad, awful." Insurance companies, bad, awful, private equity, bad, awful, physician groups, bad, awful, whatever, hospital consolidation, all bad, awful.
Well, and then sometimes we turn it around on patients.
Oh, yeah.
That's what's happening right now. The reason you're sick is because you ate Fruit Loops.
Or the reason why you don't adhere to this medication, or you don't do this. And is there a place for personal responsibility?
Of course.
Absolutely. But that is for all parties involved, policymakers, payers,
And a
pharmaceuticals.
recognition of obstacles that prevent people who want to take care of themselves from doing so.
Right. So let's kind of now go back. So you've got all the incentive issues that are misaligned basically because of fee for service. And there's likely good from fee for service in some ways. I mean, the potential for profitability is the engine for innovation, right?
Right.
So like there is a reason why profitability can be good, because it's a reason why people want to create and want to, because money does drive people. It's not necessarily a bad thing.
Oh, I've got a women's healthcare company, and I'm constantly saying investing in women's health is not a charitable, like it's not a tax deduction. It's not a impact charitable. I'm going to make you filthy rich if you invest in my company.
Right. That's going to have a positive impact.
We're going to change the world to respect women in a better way.
So exactly. So there's a benefit to that incentive.
That's how
It's
the world
dual-
works.
Right.
That's just the way it goes.
Well, Laura, I don't know about you, but like the incentives in healthcare, there's a lot of them, and there's a lot of misaligned incentives, and I think that we could talk a really long time about it. So
Hours.
hours,
Till the paint
hours,
dries.
till the paint dries. I know it's not the super exciting like Code Brown kind of conversations, but
It's not all of medicine is super sexy.
no,
No.
but it is one of the fundamental reasons,
Right.
I think, that we are unstable in our healthcare system in the U.S. So here's what I propose. I don't know if you're okay with it, but I think what we should do is we talked all about some of the drivers of the incentives and things at the beginning, and some of the different incentives for different people and how they were kind of wonky and going different directions. But what if we take a break
Okay.
and we come back and talk about some of the other kind of things that are going on with incentives? Then we talk about how about solutions, actually, like how we could fix this.
Stop the moaning and do something
I know,
about
and
it.
actually do something about it.
Okay.
And then have some controversial conversations, I think, around like, is the healthcare system in the U.S. truly capitalistic, or is it socialistic, or should it be some hybrid, or is it a guided healthcare system? What really is it? And I think that could be part two, because this is going to be a long conversation. What do you think?
We need people to be able to go out and get an apple, a healthy snack, and maybe a walk around the block.
I mean, I think that would be great.
Okay.
I mean, that's a good place to start. So we're going to end this episode,
Okay.
and then we'll start episode 2. How does that
Okay.
sound?
Well, that
Okay.
sounds fun. See you
That sounds
later.
Great.
Thanks for tuning in to Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit unstablevitals.com to stay in the loop. And don't forget, real change starts with real talk. See you next time.